I want to tell you the story about, well, this is almost Mike's story, although Mike is the RT. Mike is not the patient. And so the team got wind that there was this opportunity to say how we're going to do something different around our care services. And so we looked at the demographics and what was happening. Of course, the same physicians and team members in the community also served the hospital. Well, asthma was the number 3 reason for visits for emergency room visits in Taber. And there's a respiratory therapist at the hospital 1 day a week that traveled through all of the different rural communities. So he was in Taber 1 day a week. With this new opportunity for team-based care, then Mike worked with the team to say, okay, well, let's look at what we can do. How can we make things better? Mike didn't get more time. This wasn't an opportunity where let's buy more of Mike's time so that he can work with the team. He was going to be in Taber 1 day a week, that's it. But what they did is instead of being in the hospital 1 day a week, Mike moved to the clinic a half a day a week and the hospital the other half. So he split his time. And when he was in the clinic, then he looked at their system with them. He said, okay, how do people with asthma come through? To what extent are you diagnosing people with asthma who really potentially have COPD? How can we support the system that's happening in the clinic? And what they discovered was that the spirometer that they were using in the clinic wasn't being calibrated properly, so it was leading to a lot of rework, a lot of misdiagnosis. So he was able to help them with that system. There was lack of information about who had action plans, who didn't have action plans, and so they were able to work on that system. And so they moved a step ahead to the system-based planning, and all of a sudden the emergency room visits to the hospital dropped by about 50%. And so it went down to the number 9 reason for emergency room visits. Well, those physicians were pretty pleased because they're the ones leaving their suppers and leaving their home at night, to go to those emergency room visits. Now, that was a huge success. And you know that once you've maintained a success like that over a few years, it's pretty hard to get another level of success. And the point here is that in those early days, we were starting to hear about the chronic care model. We understood some of those principles, but we hadn't yet heard about the model for improvement. Now, when the model for improvement came into play, and when there was opportunity to have a structured process to improve the way things went, then the group participated with others in a collaborative. The collaborative had nothing to do with asthma. Or I shouldn't say nothing. It wasn't focused on asthma. It was about access, efficiency, and planned care. And so but in fact, there was not an asthma-specific component. Through that collaborative, there was a further improvement in emergency room visits related to asthma because the team started to understand the underlying concept of maintaining continuous quality improvement in everything that you do as a team. And so the benefits just spread. And I think that this is a really, really telling piece right here, is how to understand that continuous support. So this actually is this is to illustrate another point related to team, which is that as part of that, initially when that group was working on access, in fact, then the physicians thought that access for appointments to the physicians was a physician issue. So it doesn't flip a switch. When we move to teams, sometimes, in fact, it takes a little bit longer to spread that culture and that paradigm to everything that we do. So even though there had been so much success in other areas from a team-based perspective, when it came to access, they still started by saying, let's pull together as physicians and figure out how we're going to do this. And that's when they got very little, they got no traction. And then when they said, okay, well, let's go back to what's worked for us before and bring in the whole team and ask for help and advice, then right away the team, and it was the receptionist, said, oh, now we get it. That's what you're on about. Okay. All of a sudden, access improves dramatically. Team is the big success factor. So now patients don't travel near as much, and there are way more integrated opportunities. They started being frustrated, and I know people are I'm very aware of time here. They were teasing me because I do have a lot of slides. I'm okay? All right, okay. So they asked themselves, when we started, we were very frustrated. And a lot of teams start from the perspective that they think it's just not going to get any better than this. This is just the way it is. There are way too many demands on our time than we can possibly meet. But through this, they actually have a sense of purpose and focus, and they feel like they can move forward. They look for evidence and apply it now. Before, there was fragmented care, there was duplication, they were on the treadmill consistently. So now, in fact, they have a sense of team, of an integrated program that's going on, and mapping. They map the service flow so they can answer the questions about, who provides what care. What is the role of the specialty program relative to the role in the family practice? What is the role of the physician relative to the role of the nurse or the dietitian that they've now brought into the practice? They can answer those questions with reliability right now. And they're still working hard, but they're achieving more. And in the achieving more, actually, part of that is they're able to reach out to a greater percentage of their population. And I think that's a huge success. Part of the work that we're doing is not just to provide the better care to the people who get in, but I'm sure you're all aware of the people who aren't getting in. And so they wanted to improve things so that more of the population could access their services. They can offer more options to patients. They have improved chronic disease management and training, and they're offering regular training in terms of that interaction to move to more of a coaching-based model that promotes self-care as well. So as I say, Tabor then was a demonstration, and it was the most heavily researched, but it spread. And so this spread throughout the region, which serves about 100 to 110 physicians. And each of the 17 family practices then now have the internal allied professionals, and each of the teams has hired new internal team members to boost their team functioning within the clinic practice. Plus, they no longer refer to a diabetes education center if they need that level of support. They refer to Jenny. Every clinic is linked to a person that they're going to refer to outside so that they can build a relationship and they can have a common way of communicating together. No more of this phone tag, this random phone tag where you're trying to reach 2 or 3 physicians or 2 or 3 different home care nurses or 2 or 3 different educators from that center. They are linked on a personal level to form a team, even when they're housed and paid for through different structures. They had to try a lot of new things. And so case conferencing was one of them for physicians, pharmacists, and home care. And they just wanted to start with the small, let's pick 3 clients and just get going. But what they learned in the testing of it is initially there was a little bit of that paralysis. You might think, well, it's only 3 clients. What's the paralysis about? Well, because people wanted to make sure that their charts were really up to date before they met. And, they didn't want to meet and look bad, right? But they didn't have time to do that. And this was at a time where home care was switching actually to MDS, and so there was work to do. Well, so that was frustrating. So people had to let that go. They had to drop that because the work was happening anyway. And instead they said, you know what? Here we see each other in the hallway. Let's just sit and do it. And they did it, and that got them over the hump. So that was very helpful to them to just realize they didn't have to be perfect before they talked. Their charting didn't have to be perfect before they talked to somebody else in a formal way. Although, of course, charting is very, very important. So in terms of chronic disease, then in fact what they did initially was they were looking at, let's encourage the physician to refer more appropriately into these programs, whether they're inside the clinic or outside the clinic.